Hi everyone, in this video we're going to take a close look at the acute coronary syndrome algorithm. And this is a big one because this is where we can really save lives. Remember, the biggest killer of Americans, all Americans, is heart disease. So, it starts with the patient presentation. It's the patient complaining of chest pain, shortness of breath, symptoms of an AMI. Remember, in women, an unusual fatigue, just the complaint, the symptom of an unusual fatigue in a female is suspect for AMI, just by itself. With no other symptoms, that by itself can be considered for an AMI, so look closely. First, you want to get a set of vital signs on your patient. And when it comes to blood pressure, a good habit is to take a blood pressure in each arm and look for any deviation greater than 15 millimeters of mercury, as this may suggest a dissecting aorta. And especially in the older population, the symptoms between a dissecting aorta and an AMI can be kind of vague. We don't want to miss something, so remember, pressures in both arms. Get an SpO2. The literature says if their SATs are less than 90%, you want to administer oxygen. And our goal for saturation overall is between 94 and 99%. Now, low flow oxygen, 2-4 liters, we really don't have to worry about oxygen toxicity right now. That's for later on during ROSC when we're pumping 100% oxygen into them. That's another story. But low flow, no risk for oxygen toxicity. Get a history on this patient to include allergies, medications, any medical history if they had this before. If so, what happened then? Next, your therapies. 1, get a 12-lead EKG. Get that 12 lead and report it to the hospital immediately. Now we look at our treatments that we're going to perform in the field. And we can use the acronym MONA to help us. And MONA stands for morphine, oxygen, nitro, and aspirin. Probably the first drug you're going to administer is aspirin. Anywhere from 160 to 325 milligrams of aspirin. Baby aspirin that can be chewed up and hits the circulation quicker. That's why we use baby aspirin. It's not coated and it gets into the system quicker. Now, aspirin is an antiplatelet. It keeps platelets from clumping together. In the coagulation cascade, the first thing that happens is platelet aggregation. These platelets clump together. Aspirin can help inhibit that, and that's why it's so beneficial during an AMI. Next, N stands for nitroglycerin. Follow your local protocols regarding the administration of nitro, but you must ask the patient, have they taken any phosphodiesterase inhibitors, Viagra, Cialis, within the last 24 to 48 hours? And ask them. And the response you may get is, I don't need that, I don't need those drugs. The male ego. Then tell them, okay, but if you've taken those medications and I give you this nitro, it's going to potentiate, it's going to drop your blood pressure, and I can't guarantee you're going to make it to the ambulance. Oh, Viagra, I thought you said orange juice. Yeah, man, been eating them like Pez all night. So if they've taken these medications, you cannot administer nitro. Again, it potentiates its effect. You're going to drop their blood pressure and it's hard to get them back. Next, morphine. And morphine has a couple of benefits when administered during an AMI. One, it causes vasodilation, which can reduce preload to the heart, and actually can improve coronary perfusion. Another attribute of morphine is it helps to relax the patient. If your patient's scared, anxious, tachycardic, giving him a little Groovacaine helps to calm them down a little bit. And this directly reduces the amount of catecholamines being produced by the patient. These are all sympathomimetics. Epinephrine is going to cause the heart rate to go up, beat harder, beat faster. Now this heart with disease, coronary disease, is working harder. That's like pushing the gas pedal on a motor with gumped up fuel lines. So giving them a little morphine helps to relax them. Now, morphine can be contraindicated as well as nitroglycerin in inferior wall MIs. I talk about that more in my lecture called Nitro in the Inferior Wall MI. We're not going to get into it here, but take a look at that because nitro and morphine can be contraindicated in an inferior wall MI. So get your 12 lead prior to administering nitro or morphine. Next, we want to alert the hospital with our 12-lead findings so that they can prepare to see this patient. Now, once the patient gets into the ER, pretty much the same things are going to happen that happened in the field, getting a history, getting IVs, administering medications, and additionally, we want to get a chest x-ray. Ideally, within 30 minutes of that patient arriving to the ER, we need to get a chest x-ray. Now you're saying, geez, there's some protocols where the patient goes right from the field to the cath lab. What about that chest x-ray? Well, when the patient hits the cath lab table, it's fluoroscopy, it's an x-ray, and they're going to take a scout view and look for pulmonary issues or other problems that may be causing this chest pain at the same time. So yes, you can take a patient right from the field straight to the cath lab if your system allows for that. Now, looking at our 12-lead EKG, we have 3 categories that we need to be aware of. One, and the worst, is the STEMI. STEMI, ST segment elevation myocardial infarction. That's what STEMI stands for. Ideally, we're going to take him to the cath lab and we want to get that balloon inflated and reperfuse that area of the heart, revascularize that vessel within 90 minutes of them hitting the ER. Now, right now we have the COVID pandemic going on, so patients are more often receiving fibrinolytic therapy, and that should be administered within 30 minutes of the patient hitting the door. That means a complete review assessment of the patient to include the fibrinolytic checklist, which we cover in another video, and get that drug on board within 30 minutes of that patient hitting the door. Next category is the non-STEMI event. There is no ST segment elevation. Instead, we may have ST depression or T-wave inversion, which is indicative of ischemia. Not infarct, ischemia. In this case, we want to draw cardiac labs, get our panels for labs, looking at the troponin levels, getting our chest x-ray, and watching this guy like a hawk, or lady like a hawk. Next category for our 12-lead findings, we found nothing. We got bupkis. We have no elevation, we have no depression, we don't have any reciprocal changes, we have nothing. Great, watch them, but we're going to do further testing. So going back through that STEMI category, remember you want to have vascular access on this patient. And I would have 2 pretty big IVs, an 18 in each AC would be appropriate. Because what happens if this patient cardiac arrests? If you've ever tried to work a full arrest with a 24 in the hand, good luck. So have solid vascular access for your AMI patient. Again, we want to get them to the cath lab and balloon up within 90 minutes. Or fibrinolytic therapy administered within 30 minutes. Looking more at the second category, the non-STEMI event, you still want to get your cardiac markers, and if all those are coming back positive, we still may want to take this patient to the cath lab. The last category, no 12-lead findings, cardiac markers came back negative, look for another cause for their chest pain. Okay, this has been a quick review of the highlights of the acute coronary syndrome algorithm. I'm Mark, thanks for watching. I'll see you in the next video.